You have been cutting salt for years, reading every label, putting the shaker away, switching to low-sodium everything, doing exactly what you were told, and your blood pressure is still high. Maybe it came down a few points when you started, but it never reached where your doctor wanted it, and every 3-month appointment ends the same way with the same advice about sodium, and the same medication adjustment, and the same instruction to come back and try again. And somewhere along the way, if you are honest with yourself, you started to wonder whether the salt was ever really the whole story. I want to talk to you today about why that instinct may be correct, and about the mechanism that is more likely driving your stubborn blood pressure than the sodium you stopped cooking with 3 years ago. This is not a conversation about abandoning everything you have been told. Salt does matter, and excessive sodium intake does raise blood pressure in certain people, and that is real and documented. But the research on sodium and blood pressure is far more nuanced than the public messaging suggests, and for roughly a third of the population, sodium has a meaningful impact, while for the remaining 2/3, reducing intake produces changes modest enough to be overwhelmed by a completely different mechanism that nobody has explained to them. That mechanism is insulin, and what the modern diet does to it consistently, day after day, in ways that quietly lock blood pressure into an elevated range no matter how carefully you season your food. Before anything else, what I share in this video is educational information only. It is not medical advice. Do not stop or change any blood pressure medication without speaking directly to your prescribing doctor first. What I want to give you today is a framework for understanding your own blood pressure more completely, so that the conversation you have at your next appointment is a fundamentally richer one. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. I am tired of watching patients cut salt faithfully for years, while the mechanism that is actually driving their blood pressure goes unaddressed. They are working hard, following instructions, doing the right things, and the instructions they were given are incomplete. That gap is what this video is going to close. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body is communicating after 60, and this video may fundamentally change how you think about blood pressure management. Let me start with how blood pressure is actually regulated in the body, because most people have a simplified picture that makes it harder to understand why the salt focus falls short for so many adults. Blood pressure is the force that blood exerts against the walls of the arteries as the heart pumps it through the circulatory system. It is determined by 3 primary variables. The first is cardiac output, which is how much blood the heart pumps per minute. The second is peripheral vascular resistance, which is how much resistance the arteries offer to that flow, depending on whether the arterial walls are relaxed and wide or constricted and narrow. The third is blood volume, which is how much total fluid is circulating in the system at any given time. Most blood pressure medications work on one of these variables. Beta blockers reduce cardiac output. ACE inhibitors and ARBs relax the arterial walls. Diuretics reduce blood volume by promoting urinary fluid excretion. They are effective tools because they address specific parts of the regulatory system directly. But here is the question that rarely gets asked. What is causing the blood pressure to be elevated in the first place? Not which variable is expressing the elevation, but what is driving that variable upward continuously. Salt, when consumed in excess, raises blood pressure primarily through blood volume. Sodium draws water into the circulation. More water in the circulatory system means higher blood volume, which means higher pressure against the arterial walls. The body attempts to compensate by having the kidneys excrete the excess sodium and water, and in most healthy adults with functional kidney responses, it succeeds. Blood pressure rises after a salty meal and returns to baseline within hours as the kidneys clear the load. But when blood pressure stays elevated consistently, including between meals and overnight and in the morning before you have eaten anything at all, something is preventing that normalization. Something is keeping blood volume elevated. Something is keeping the arteries in a state of higher resistance than they should be at rest. And for a growing body of research, that something is not primarily the sodium sitting in your food. It is the hormonal environment created by chronically elevated insulin. Type in the comments right now how many years you have been actively reducing sodium and whether your blood pressure has responded the way you were told it would. Because the answers in those comments are going to tell a story about how many people have been managing the wrong variable while the real driver continues unchecked. And before we get into that driver in detail, I want to add one more piece of context that is almost never included in blood pressure discussions, but that directly affects why the insulin mechanism is so persistently invisible in standard care. Most blood pressure readings are taken at a medical appointment in the middle of the day, after the person has been sitting quietly in a waiting room, without any measurement of what their blood pressure is doing overnight or in the morning before their first meal. This single-point measurement in a controlled clinical environment systematically underestimates blood pressure in people with nocturnal non-dipping and morning surge patterns, and it systematically misses the window in which the insulin-sodium mechanism is most actively driving the pressure upward. A person with well-managed daytime blood pressure and persistently elevated overnight pressure from the insulin-driven sodium retention I am going to describe may look controlled at a clinic visit while experiencing the cumulative vascular damage of uncontrolled hypertension during the 8 hours they are asleep. This is one of the reasons ambulatory blood pressure monitoring, a device worn for 24 hours that captures readings through the full day and night cycle, produces such a different picture from clinic readings in many patients. The nighttime and early morning readings are where the insulin mechanism is most active, and they are the readings that standard care most often misses. The insulin-sodium connection is the piece that most standard hypertension conversations completely omit, and understanding it changes the picture entirely. Insulin is the hormone released by the pancreas in response to rising blood glucose. Its primary role is to signal cells to take up glucose from the blood, driving blood sugar back toward normal after a meal. But insulin also has a direct effect on the kidneys, and that effect is what connects it to blood pressure in a way that most people have never been told about. Insulin signals the kidneys to retain sodium. This is not a side effect or an abnormal response. It is a physiological mechanism that appears to have evolved as a means of supporting blood pressure during periods of recovery, when holding onto sodium and water would help maintain adequate circulatory volume. Under normal conditions, when insulin rises after a meal and then falls back to baseline over a couple of hours, this sodium-retaining signal is brief, and the kidneys re-establish their normal balance. But in a person with insulin resistance, whose cells do not respond normally to insulin's glucose-clearing signal, the pancreas compensates by releasing more insulin than it would in a person with normal sensitivity, more insulin to produce the same glucose-clearing effect. And that chronically elevated insulin level, present not just after meals but between meals and sometimes overnight because the compensatory secretion runs on a different rhythm than normal, is continuously signaling the kidneys to hold on to sodium and water. The kidneys comply. Blood volume stays elevated. The heart is pumping against a consistently higher fluid load. Blood pressure stays high. And no amount of sodium restriction will fully address this if the insulin level driving the retention never falls. A study published in the journal Hypertension found that insulin resistance was independently associated with elevated blood pressure even after controlling for body weight, sodium intake, and other cardiovascular risk factors. The association was direct and dose-dependent. Higher insulin resistance, higher blood pressure. Lower insulin resistance, lower blood pressure. Not because of any change in salt consumption, because of the renal sodium-retaining signal that insulin was continuously sending. This is what I call the insulin-sodium trap. The blood pressure is elevated because of high blood volume driven by sodium retention. The sodium retention is driven by chronically elevated insulin, and the chronically elevated insulin is driven by the dietary pattern that produces insulin resistance, which means that reducing salt at the table while continuing to eat the foods that drive insulin resistance is, for a significant proportion of adults over 60 with hypertension, treating the symptom without touching the cause. Now, let me talk about the dietary pattern that drives chronically elevated insulin, because this is where the conversation becomes specific and actionable. Sugar and refined carbohydrates are the primary dietary drivers of insulin resistance and chronic hyperinsulinemia. When large amounts of rapidly absorbed glucose enter the bloodstream, the pancreas responds with a large bolus of insulin. When this happens repeatedly across every meal and snack across every day across years, the cells gradually reduce their sensitivity to insulin's signal, which causes the pancreas to compensate with even more insulin, which further drives sodium retention, which further elevates blood pressure. But the story does not stop with sugar and white bread. The vehicle delivering the sugar and refined carbohydrate in the modern diet is ultra-processed food, and ultra-processed food carries additional mechanisms that compound the blood pressure problem beyond the insulin-sodium pathway. Ultra-processed foods, a category defined not by any single ingredient, but by the industrial formulation process that creates them, contain combinations of refined carbohydrates, added sugars, industrial seed oils, synthetic additives, emulsifiers, flavor enhancers, and preservatives that individually and collectively affect vascular health in ways that go well beyond their sodium content. The refined carbohydrates drive the insulin sodium trap I described. The industrial seed oils, high in omega-6 fatty acids and particularly susceptible to oxidative damage during processing and storage, contribute to the chronic low-grade inflammation in the arterial wall that stiffens the vessels and increases peripheral vascular resistance. Remember the three variables: blood volume, cardiac output, and vascular resistance. Elevated insulin keeps blood volume high. Arterial inflammation from chronic oxidative stress keeps vascular resistance elevated. Both variables are pushing the pressure upward simultaneously. The emulsifiers and additives in ultra-processed food also appear to alter the gut microbiome in ways that promote systemic inflammation, adding another layer to the vascular burden. This is a relatively new area of research, but the consistency of the findings across multiple studies published in journals, including Cell and Nature Medicine, is striking enough to be clinically relevant for any adult over 60 consuming significant quantities of packaged, processed food. A study published in JAMA Internal Medicine followed more than 100,000 adults and found that higher consumption of ultra-processed foods was independently associated with increased risk of cardiovascular disease after controlling for total caloric intake, sodium intake, and saturated fat. The association was not explained by the sodium in those foods. It was explained by the combination of metabolic effects specific to the ultra-processed food matrix itself. There is another layer to this that is rarely discussed. Many ultra-processed foods are specifically engineered to drive continued consumption beyond the point of satiety. The combination of sugar, fat, salt, and flavor enhancers in quantities and proportions not found in whole foods activates reward pathways in the brain that override the normal satiety signals from the gut. The person eats more than they intended to, more frequently than they planned, and the cumulative insulin load across the day is far higher than any conscious accounting of their food intake would suggest. This is not a failure of willpower. It is a deliberately engineered response to a product designed to produce it. I want to tell you about William, 66 years old, retired teacher from Dallas, Texas. He had been on 2 blood pressure medications for 7 years and had been faithfully following a low-sodium diet for 4 of those years. His morning readings were consistently around 148/88. His cardiologist was not satisfied with those numbers and had discussed adding a 3rd medication at his most recent appointment. When William came to me, the first thing I did was look at his complete dietary pattern rather than just his sodium intake. He ate relatively little added salt, but he ate breakfast cereal every morning with low-fat milk and orange juice. He snacked on crackers and fruit twice daily. His lunch was usually a low-sodium sandwich on white bread with a diet soda. His dinner was generally reasonable, but he ended most evenings with a small bowl of low-fat yogurt with fruit or a handful of low-fat cookies, because he had been told that low-fat was heart-healthy. His fasting insulin level, a test that had never been run despite 7 years of treated hypertension, came back at 24 microunits per milliliter. The reference range for healthy fasting insulin is generally below 10. His cells were deeply insulin-resistant. His pancreas was compensating with nearly 2.5 times the normal fasting insulin output, and those insulin levels were signaling his kidneys to retain sodium and water around the clock, including overnight, including before his morning reading, including every moment his medication was trying to work against the retention signal. His diet was low in sodium. It was not low in the foods that were driving his insulin resistance. Cereal, white bread, fruit juice, crackers, low-fat sweetened products. These are foods marketed as heart-healthy and low in salt that are simultaneously high in rapidly absorbed carbohydrates that produce exactly the insulin cascade driving his blood pressure. We worked with his primary care physician to transition William toward a dietary pattern that reduced refined carbohydrate and ultra-processed food while maintaining adequate nutrition. Whole food sources of protein, vegetables, olive oil, nuts, eggs, and moderate amounts of complex carbohydrate from intact grains and legumes rather than refined flour products. We also made one specific addition I will come to in a moment. At 12 weeks, his morning blood pressure average had dropped to 131/79. His cardiologist reduced his medication, not added to it, and told him at his next appointment that whatever he had changed, he should keep doing it. William told me, nobody ever told me that my cereal was doing this. I told him, your cereal was not the problem on its own. The pattern of repeated insulin spikes from a day full of refined carbohydrates was the problem. And nobody had ever measured your fasting insulin to confirm it. Let me now talk about what actually helps, because the point of identifying the real mechanism is to know specifically what to change. The first and most impactful dietary change is reducing the glycemic load of your overall eating pattern. This does not mean eliminating all carbohydrates, and it does not mean adopting an extreme protocol. It means replacing rapidly absorbed refined carbohydrates, white bread, white rice, pasta made from refined flour, sugar-sweetened products, breakfast cereals, fruit juice, with carbohydrate sources that carry fiber, protein, and structure that slow their digestion and blunt the insulin response. Whole grains over refined, legumes over crackers, whole fruit over juice, eggs and vegetables over cereal. The practical application is the meal composition principle we have discussed in previous videos on this channel. Eat protein and fiber before carbohydrate at every meal. This single sequence change reduces the postprandial insulin spike without requiring any reduction in total food intake. The fiber and protein slow gastric emptying. Glucose enters the bloodstream gradually. The insulin response is proportional rather than compensatory, and the sodium retaining signal from the kidney is correspondingly reduced. The second change is reducing the frequency of eating. Every time food enters the digestive system, insulin rises, not only after large meals, but after snacks, after sweetened beverages, after anything that produces a glucose signal in the blood. Adults who eat 3 meals with no snacking in between give their insulin levels a longer period of falling toward baseline between meals. Adults who graze continuously through the day, eating something every 2 hours, maintain chronically elevated insulin levels throughout the waking period, with almost no time for the renal sodium retention signal to relent. This is not about extreme fasting or caloric restriction. It is about allowing adequate intervals between eating occasions, generally at least 4 to 5 hours between meals, so that insulin has time to fall to a level that no longer signals the kidneys to retain fluid. The third change, and one of the most consistently evidence-backed dietary interventions for blood pressure beyond sodium reduction, is increasing dietary potassium. Potassium is the physiological counterpart to sodium in the regulation of fluid balance. The kidneys manage the balance between sodium retention and potassium excretion in a seesaw relationship. When potassium intake is high, the kidneys are more willing to excrete sodium and the blood volume pressure is reduced. When potassium intake is low, as it is in most modern dietary patterns built around ultra-processed food, the sodium-retaining pressure dominates. The foods highest in potassium are the foods least represented in the modern processed diet: leafy greens, avocados, legumes, nuts, and fish. A study published in the British Medical Journal found that increasing dietary potassium produced blood pressure reductions comparable in magnitude to modest sodium restriction, and that the combination of higher potassium and lower sodium produced substantially greater reductions than either change alone. The potassium piece is almost never discussed in the salt conversation, but it is operating on the same renal mechanism from the opposite direction. There is a fourth dietary factor worth mentioning specifically, because it addresses blood pressure through a mechanism that is entirely distinct from the insulin-sodium pathway, and that compounds the benefit of everything else I have described. Magnesium. The kidneys use magnesium to regulate the tone of the smooth muscle surrounding the arteries. Adequate magnesium helps the arterial wall relax. Deficient magnesium contributes to arterial constriction and elevated peripheral vascular resistance, which is the third variable we identified as a driver of blood pressure. Magnesium is depleted by the same dietary patterns that drive insulin resistance. Processed foods are low in magnesium. Refined grains have lost the magnesium-rich germ and bran. And adults taking diuretics for blood pressure management, one of the most common medication classes in this age group, lose magnesium in the urine as a consequence of the medication's mechanism. The result is a population of hypertensive adults on diuretics eating processed food who are simultaneously pushing their blood pressure up through the insulin-sodium trap and failing to benefit from the arterial relaxation effect of adequate magnesium. Leafy greens, nuts, seeds, and legumes are the primary dietary sources, and a brief conversation with your doctor about whether your magnesium level has been checked recently is worth having. The fourth change is sleep. Specifically, adequate slow-wave deep sleep of sufficient duration. During deep sleep, insulin sensitivity improves and cortisol drops to its lowest point of the 24-hour cycle. Adults who sleep 5 or 6 hours consistently compared to 7 or 8 show measurably higher insulin resistance, higher overnight cortisol, and higher morning blood pressure readings. The insulin sodium trap is tightened by poor sleep, because the insulin resistance that drives it is worsened by the hormonal consequences of sleep deprivation. A study published in Hypertension found that adults with short sleep duration had significantly higher rates of hypertension than those with adequate sleep, and that the association was partially mediated by increased insulin resistance in the short sleepers. Sleep is not separate from blood pressure management. It is a direct metabolic input into the mechanism. And if you are not yet subscribed to this channel, tap that button now and ring the bell. Because every week I bring you exactly this kind of specific, layered, research-grounded information about what your body needs after 60. Let me now address the role of fasting insulin testing, because this is the investigation that most adults with difficult-to-control hypertension have never had, and that most fundamentally changes the conversation about why their blood pressure remains elevated. Fasting insulin is not a standard component of a routine blood panel. Fasting glucose is standard. HbA1c is increasingly standard. But fasting insulin, which reveals not just what the blood glucose is doing, but how hard the pancreas is working to maintain it, is almost never included in a routine hypertension workup. Yet, fasting insulin is the test that directly measures the insulin sodium signal, acting on the kidneys. A fasting insulin above 10 microunits per milliliter in a resting fasted state is an indicator of meaningful insulin resistance. Above 15 is significant. Above 20 reflects the kind of compensatory hyperinsulinemia that is likely producing continuous renal sodium retention and contributing to blood pressure that is difficult to manage with medication alone. Ask your doctor specifically for a fasting insulin level at your next appointment. It is a standard laboratory test available at any facility that runs blood work. Bring this video if necessary. Tell your doctor you want to understand whether insulin resistance is contributing to your blood pressure. The conversation that follows that result, if the number is elevated, is different from every previous conversation you have had about salt restriction. If the fasting insulin is elevated, the management path is clear. Reduce the dietary drivers of insulin resistance through the changes I have described. Allow the pancreas time to reduce its compensatory output, and monitor whether the blood pressure follows as the insulin level falls. In many cases, it does. The blood pressure reduction that follows improved insulin sensitivity is not a minor effect. It reflects the removal of a continuous hormonal pressure on the kidneys that no amount of salt restriction could have addressed. Type yes in the comments right now if you have been managing hypertension for more than 3 years and have never once had your fasting insulin measured, because that yes represents every person whose blood pressure management has been aimed at one variable while the mechanism driving it has been invisible. And share this video with one person in your life who has been cutting salt faithfully and watching their blood pressure refuse to respond, because the explanation they deserve is the one I just gave you. Here is the complete framework I want you to carry away. Blood pressure is regulated through 3 variables: cardiac output, vascular resistance, and blood volume. Salt raises blood volume temporarily, but the kidneys correct it in people with normal physiology. When blood pressure stays elevated despite sodium restriction, something is maintaining a continuous elevation of one or more of these variables. The most commonly overlooked driver is chronically elevated insulin from insulin resistance, which signals the kidneys to retain sodium and water continuously, keeping blood volume elevated and blood pressure locked in a higher range, regardless of how much salt is removed from the diet. The second driver is the chronic arterial inflammation, from the oxidative compounds and omega-6 imbalance of ultra-processed food, which increases vascular resistance. The third driver is inadequate magnesium, which prevents the arterial walls from relaxing. All 3 are operating simultaneously in many adults over 60 with difficult-to-control hypertension, and all 3 are being driven by the same dietary pattern that nobody addressed when salt restriction was prescribed. The dietary pattern that drives all 3 mechanisms is built on rapidly absorbed refined carbohydrates, added sugars, frequent eating that prevents insulin from falling between meals, and ultra-processed foods that deliver the glycemic, inflammatory, and mineral-depleting effects simultaneously in every meal, every snack, and every sweetened beverage. The changes that address this mechanism are reducing the glycemic load of the diet through food quality and meal sequencing, reducing the frequency of eating to allow insulin intervals, increasing dietary potassium and magnesium through whole food sources, and prioritizing adequate sleep to preserve insulin sensitivity through the overnight hours. The test that makes this entire picture visible is fasting insulin, a standard laboratory measure that is almost never ordered in a routine hypertension workup, and that directly reveals whether the insulin sodium trap is operating. Docs ask for it by name. It costs almost nothing, and it will tell you more about why your blood pressure is behaving the way it is than any amount of sodium tracking has. You are not failing at blood pressure management by being unable to control it through salt restriction alone. The restriction was addressing one variable in a multivariable system. The other variables have been running unchecked. Now you have a complete picture of all of them. Share this video with someone who has been fighting their blood pressure with one hand tied behind their back because nobody told them about the other driver. And subscribe to this channel because every week I come here with one purpose: to give you the framework that makes your next medical conversation fundamentally more effective than the last one. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.